movimento modarka, üres a kalitka.
Hello, I'm Kathy Callahan with Encompass. We've been working this year with UNAIDS and with co-sponsors and partners from around the world to examine the question of intensifying HIV prevention and the importance of leadership on prevention from wherever we sit all around the world. And along the way, we've been struck by the voices we've been hearing, by the messages from people at the community level, the voices of people at the national level with regional expertise or content expertise. We've been really struck and energized by the voices that we've heard and the excitement and the passion around making a difference through HIV prevention. And so even in this low-tech, low-cost way, we wanted to gather some of those voices for you so that you could feel that same passion and energy as you begin to lend your voice to this conversation as we move forward in a prevention revolution and in looking at ourselves from wherever we sit as leaders in HIV prevention.
Prevention. That is the only way to turn off the tap. You cannot treat yourself out of this epidemic. We know that. Yeah, but the question is, how are you going to be able to translate it in such a way that the message is actually heard?
It's really important that we close the tap, as it were, of HIV infections so that we can get as many people on treatment as possible. If we don't focus on prevention, we won't reach our treatment goals.
Treatment and mitigation of impact by themselves simply translates to a no-win situation.
Our prevention programs diminish if we take our eye off of the importance of them.
There's no way we can make genuine progress without addressing the new caseloads of HIV to deal with.
The next cohort, the next age cohort, 5, 6, 7 years earlier than for people who are currently being infected, are moving into risk behaviors, trying out sex, possibly trying out drugs, and we have to start all over again.
Treatment, testing, and prevention are part of a triad that support each other. We can't have successful treatment without successful prevention, and testing is an essential component of both.
So I say that one works for the other. There's a synergy between prevention efforts and treatment.
I would plead with our leaders of prevention not to pit one strategy against another.
But clearly, if somebody is on treatment and is responding positively, it has a huge payoff for prevention.
We can do both.
Let's talk about the political leadership, the religious leaderships, the community leadership.
We will always need the commitment and the leadership from those at the very highest levels of government, because this is an area that they need to be courageous, they need to devote their resources, they have to deal with all the competing priorities.
But let's also talk about people at the community level who are impacted upon, because the community leaders make a huge difference.
I see it as the communities are the generals who are ahead of the troops. Yeah? So we have to say, look, let's catch up with the communities.
Please invest in the leadership of people living with HIV at country level, at all levels actually. But the more that you invest in community-based PLHIV directed services, the more success that you'll have in addressing prevention in communities.
But access to help is a human right. And when you're talking about access to help, you're talking about prevention, preventing infections, and treating people who are already infected.
So in such situations, your best foot forward is, again, knowledge of your status, okay? Not just of your status, but also of your partners.
Scaling up the provision of male and female condoms, because even when there is a desire, even when there is interest in using condoms, often both men and women, but particularly women, are not in a position to make decisions around it. They don't know how to access it. Sometimes it's even illegal to own a condom in certain contexts. Preventing HIV among women will first of all by itself prevent mother-to-child transmission, that mothers will not be infected, children will not be infected. But more importantly, contraception and its role has often been forgotten. If women had intended pregnancies, if women had less pregnancies, if women were in a position to plan when they had their pregnancies, they would be much less vulnerable to a lot of complications that result. This is equally true of women who are not infected, but it is particularly true of women who are infected.
It's really important to focus on prevention because we need to look at the undiagnosed cases, people living with HIV who are walking around not knowing their status. It's really important for prevention interventions to identify those people so that they can also get prevention services and eventually the treatment that they need.
These are preventable deaths. That's the simple truth. These are two parallel tracks that need to really be brought together. We really need to do much more on the HIV side to integrate TB monitoring and referral.
Sex workers, for example, in the context of women, and the violence that they suffer often goes unnoticed. And often this violence is related to whether they will agree to use condoms or not.
Stigma and discrimination is the greatest obstacle to access to services, both prevention and treatment. And it's extremely important that when we're looking at people living with HIV and the environment that they're living in, that we address the causes and places of stigma and discrimination.
It is, to me, the core of the response to this epidemic, the recognition of what it takes to provide services to so many populations, the overall prejudice, the taint, the stigma that surrounds this infectious disease, mainly because of the ways it's transmitted.
And it's really important to address those places in which stigma is occurring in order that people living with HIV can access prevention services, but also that they can fully employ the various prevention tools that they have in combination prevention.
I mean, the stigma that surrounds HIV and AIDS is multidimensional. There's how people get the infection and the behaviors that are associated with that, the populations that are sometimes associated with those behaviors. There's also a stigma surrounding a terminal illness. It's the same stigma we see with cancer. And you see a lot of that still in healthcare workers.
We now have compelling evidence that shows both the direct and the indirect linkages between violence against women and transmission of HIV, as well as between discrimination against women living with HIV and access to care and treatment. So the linkage between HIV and violence against women and girls is now well established.
If you want to talk about gender, women and girls, it's basically to find out what is happening, what's actually going on underground.
We are showing that some of the more traditional approaches to prevention, like focusing on youth, looking at delaying sexual debut, partner reduction, condom use, actually works. And we now have 15 high prevalence countries where we've seen 25% reduction in new infections in youth, 15 to 24. So that's an incredible accomplishment.
In the context of the vulnerability of women, girls have a much larger possibility of being infected than women. We know that girls get infected quite often because they are not in a position to negotiate, but in the power structure, they suffer in terms of their age as well as their gender.
and because there's no quick fix, but we managed to understand much more about it.
I know your epidemic work that UNAIDS strongly promotes the use of the modes of transmission tools so that people who are actually planning the prevention response or trying to improve the prevention response, because there are prevention programs going on, and to use that information to better understand where the most recent infections were occurring, where the next set of infections are most likely to occur, so that we can really focus, particularly in these times of the economic crisis, we can really focus on people who are most at risk.
No single HIV prevention approach works. You need combination prevention. You need to know the epidemics in order to design the right kind of programs for the right kinds of populations in the right kind of context. And that kind of study or that kind of analysis is imperative. Otherwise, you're wasting your resources, you're wasting your time, and you're, in fact, putting people at risk because you're not addressing the needs as they are the most urgent.
I think we are talking about not reinventing the wheel, but looking at what we are doing and what we are doing good and we are doing right and doing much more of what is working.
So it's also staying up with the literature, looking at where is the research showing we should be going, looking at the mix from biomedical interventions like PrEP or PEP or PMTCT, to behavior change like partner reduction, to social norms and structural determinants as far as what drives people into risk behavior. And so being able to get that right balance based on the situation that they're confronting. So all of